All right, let's start talking about the lungs. So, in the cardiac section, I used heart failure as kind of our big disease that we started with, and we really used that to kind of flush out our cardiac review. In pulmonary disease, it's really helpful, in my opinion, to use the three big heavy hitters that we see over and over again in pulmonary disease. And those are going to fall into two main categories. There are restrictive lung disease, and by restrictive, we mean it's hard to get air in. It's very hard to get air in. And the big disease we're going to use to talk about is pulmonary fibrosis. The other large category of disease is called an obstructive pulmonary disease. And in all diseases that fall into this category, the problem is they can't get the air out. So in obstructive, the air can't get out. I don't have a good one for restrictive, but I think restrictive kind of almost feels that way. Like if someone was wrapping a band around you and then said breathe in, you would be restricted and you wouldn't be able to get your air in. So I'm going to use these three diseases. So what I'm going to first do is introduce them, kind of the pathology of these diseases, where they come from. And then we're going to step back and be like, wait, let's remember what the anatomy of the lungs is and how it works. And then we're going to keep applying it to these three diseases. So we're going to go through the pathophys of each one first, and we'll start with restrictive lung disease. And the big player here is pulmonary fibrosis. As it says in your notes, pulmonary fibrosis falls under the much larger category of chronic interstitial lung disease. And there are a number of diseases that fall into this category. So your textbook has a nice long list of those. I didn't want to muddy your notes with a lot of nitty-gritty details because this is a pretty diverse collection of diseases, but they all share a very common phenotype of a restrictive lung dysfunction where you can't get your air in. Since pulmonary fibrosis is one of the most common, we're going to use that as our main tool to appreciate and understand what restrictive lung disease is. Because once you understand how a restrictive lung disease works, you can apply those principles to lots of other specific diseases down the way. So pulmonary fibrosis is really a general term, even within itself, of a variety of disorders that cause ongoing epithelial damage, which ultimately scars the lungs. The name fibrosis tells you that there is scar tissue being laid down. As I've mentioned a couple times already, it's really good to keep in mind that in pathology, once the scar tissue is laid down, it's not going away. There's no treatment to remove it. We have to live with it and try to prevent, more scarring from happening. So this collection of diseases that falls under pulmonary fibrosis is a disease of abnormal wound healing in the lung that repeatedly damages the epithelial tissue and slowly and eventually scars the lung. Because of that, it can be helpful to kind of boil this down to one driving principle. And if you think about pulmonary fibrosis, if you think about restrictive lung disease, they result in stiff lungs. Stiff lungs, imagine, a stiff dried sponge that you're trying to get to take anything up and it's really hard to stretch. That's the lung of someone with pulmonary fibrosis. So idiopathic means that we don't know why it's happening, and about 2/3 of the cases are idiopathic. We really don't know, what's the initiating cause. For sure, we can't point to one thing. About 1/3 of them are following a certain kind of infection. So TB, and there's a whole host of sclerosis that can cause this in response to cystic fibrosis. And then something called acute respiratory distress syndrome, which is what a lot of the severe COVID patients are ending up in. So there's a fear of some of these long-term effects down the road for some of these patients. On average, fibrosis is diagnosed between 50 or 70 years of age. So let's talk about what happens in the lung. And I'm going to go to my whiteboard to kind of draw my cartoon version of this. I'm going to draw the lung as a single alveoli, just to keep our picture simple. So here's just one alveoli. That's going to kind of represent what happens in the lung for our patients with pulmonary fibrosis. Very close to each one of our alveoli are capillaries, because we need really good surface area for gas exchange to happen between our alveoli and our pulmonary capillaries. So this guy here is a capillary, which allows for gas exchange. And the goal here is, maybe we can draw even some little red blood cells floating by. As the red blood cells show up and float by, they need to pick up oxygen. So the oxygen, right, becomes in from our mouth and the atmosphere, gets into the alveoli, and then it has to diffuse across the alveolar membrane and then cross the capillary membrane to hop a ride on a red blood cell. So that's what normally happens. That's what's supposed to happen. So I'm just going to erase this arrow so it's not in my way and talk about the steps of fibrosis, or kind of generally a restrictive lung disease. In pulmonary fibrosis, let's start with the lung is going to experience some kind of an injury. And that's why about a third of the cases you see after something happened to the lung, an infection or cystic fibrosis that's causing a lot of damage to the lung. When something damages the lung, it can respond with this abnormal wound healing. But there are a lot of other things that aren't as easy to pinpoint, right? 2/3 of the cases we don't really know, but it is likely that some kind of repeated injury is happening in your lung. And by repeated injury, I mean a good example could be that you're a smoker. So smoking could be a repeated injury to your lung that could lead to the steps that we're about to describe for pulmonary fibrosis. GERD, gastroesophageal reflux disease, is when stomach acid can reflux up into the esophagus. When that happens, bits of stomach acid can actually get aspirated or breathed into your lungs. So repeated exposure to even small amounts of stomach acid in your lung can over time be a source of repeated injury. A really big one in pulmonary fibrosis is occupational exposure. For years and years, this disease was called miner's lung, because this is the type of lung injury that patients get when they're breathing in toxic particles and poorly ventilated gas spaces. That is the repeated injury that can lead to pulmonary fibrosis. Also on here would be repeated viral infections. So we know the type of injuries that can lead to pulmonary fibrosis. The problem is that not enough people who smoke or have GERD or work in a mine get pulmonary fibrosis. So because not everybody gets it, in fact, kind of a small percentage get this disease, you really can't say it's just from smoking or it's just from GERD. There has to be some, so in addition to this, we have to give a plus sign, there has to be some genetics and age involved. That you get to a certain age and you're just more susceptible. Because again, as it says in your notes, people aren't diagnosed with this typically until they're 50 or 70 years old, somewhere between there. This is an older person's disease. And it's not enough just to be old and smoker. So there has to be some genetic component as well. So here's a big thing to note about pulmonary fibrosis. In response to repeated injury, and maybe I'll even draw kind of little green circle arrows to show this is happening over and over again. This lung is experiencing some kind of stressor. In response to repeated injury, the body responds with abnormal wound healing. This is a disease of abnormal wound healing. So what you might think, if someone's having repeated injury in the lung, what you might guess would happen is they'd have some kind of acute inflammatory response. And that is not the case here. Instead, what happens in response to the repeated injury is the body calls to action fibroblasts and myofibroblasts. So this little star guy is going to be our fibroblasts and our myofibroblasts. The only difference between a fibroblast and a myofibroblast is that a myo, as it implies at the beginning, has almost a muscular-like structure to it. I'm just going to draw a little picture here. They almost have like finger-like processes that reach out and tug the tissue in. So you know when you're healing and you almost see like that tautness of your skin, that's because a myofibroblasts are laying down collagen and then kind of contracting and pulling it away. So in response to repeated injury, when somebody is going to develop pulmonary fibrosis, they activate fibroblasts and myofibroblasts, and I would even say they stimulate excessive fibroblasts and myofibroblasts. So we could maybe even draw a bunch of them in here. I don't want to make my picture too messy, and I write excessive because this is a disease of abnormal wound healing. So what do fibroblasts do? Right, they show up on the scene and they start spewing collagen. So if you have excessive activation of fibroblasts and myofibroblasts, they are going to lay down excessive amounts of collagen. Too much. My collagen scarring is almost always black X's. So we're going to lay down. This is our collagen deposition. As the collagen gets laid down, we have to remember what's supposed to be happening at this scene. This is the site for oxygen diffusion to get into the blood. So as the collagen is deposited in this area, this is going to severely increase the thickness of that diffusion area. The oxygen's going to have to move through all this collagen to get to the blood vessel. So the big effect here is this is going to reduce diffusion. The ability of oxygen to move from the alveoli into the blood vessel. The abnormal activation of fibroblasts causes excessive collagen deposition at the alveolar capillary junction. This thickens and scars that junction between our alveoli, which are holding all of our oxygen, and the blood vessels that flow by. The other part, and I drew this intentionally, if you're looking at these black X's, you see they're not just on the alveolar wall. In fact, they're kind of extending and touching the blood vessel. That's because this disease can ultimately also damage the blood vessels. Because the alveoli and the capillary are so close to each other, they're just butted up against each other, so close because we want them that way for gas exchange, that when you start just laying down scar tissue, some of it's going to get laid down in the blood vessel. And in fact, you can scar down the blood vessel and actually destroy the ability to drive blood through that vessel at all. So this is a good picture to keep in your mind when we start talking about how the lung is affected by the disease of pulmonary fibrosis. The intersection between the alveoli and the capillary gets scarred down. that is going to make this alveoli incredibly stiff, right? When you're trying to get more air in, it's going to be very hard to stretch it because it's going to be wrapped in scar tissue. And then the oxygen that does get in is going to have a heck of a time getting into the blood vessel because of all this scarring that's in the way of diffusion. A very big thing to remember is that nowhere in this story is there acute inflammation. And I'm mentioning that again because, as you guys now know very well, when you have acute inflammation, you have increased permeability and you get edema. We are going to be talking this unit about what liquid on the lung does, but it is a very different presentation than someone who has fibrosis, because fibrosis, there's no fluid here, there's no edema, there's no effusion. This is a dry disease in terms of the lung. It is a disease of abnormal wound healing, not an inflammatory disease. Again, we're leading with the story, and then we're going to go through all the different things our lungs do, and we're going to relate it back to this story. And it will help if you can remember that fibrosis is a dry disease. There's no edema. There's no fluid accumulating in the lung. And the excessive deposition of collagen makes the lung stiff, very hard to get air in, and thickens the barrier to diffusion. So when we initially were talking about pulmonary fibrosis, I showed you this picture, and it was meant to really illustrate how close all these cells are, how very interrelated the alveolar wall and the capillary wall is. So here is the alveolar space. Here is the alveolar capillary junction, because here we are inside the lumen of the blood vessel. So when you start getting scarring, you can see it can affect both the wall of the alveoli as well as it can affect the blood vessel. Here is a picture of someone who died of pulmonary, or the lung of a patient who died of pulmonary fibrosis. You can see the entire lung gets smaller because it was stiff and scarred down. And over time, it gets less and less and less air in, which is obviously going to limit this patient's abilities because that's going to limit their oxygen. So of our three primary diseases, that is our restrictive lung disease. Let's now go on to obstructive lung disease. And obstructive lung disease is a disease where it's difficult to get the air out. And there's two main primary diseases, emphysema and chronic bronchitis. Chronic bronchitis is not the same thing that you might have been diagnosed with in your life if you've had acute bronchitis, an acute irritation of coughing and productive cough. That is not in any way the same thing as chronic bronchitis. I just want to clear that up right off the bat, because sometimes when you can relate to something, you're like, oh, I've had bronchitis. It can steer you down like a mental path that might lead you the wrong way. So it's a very different disease. So on the top of page 89, you'll see the term chronic obstructive pulmonary disease, COPD. The general definition is this is progressive disease causing chronic airflow limitations that is not reversible. These are changes that once they are there, we can't go back in time and fix. So the most important thing is to not damage it in the first place, to stop smoking. This is the main smoker's lung disease. COPD is actually an umbrella term for both emphysema and chronic bronchitis. And truly, in the clinical world, patients typically have some of both of those diseases because they're both caused by smoking and some other things as well. But COPD can sometimes present more like emphysema or chronic bronchitis. So I think at this stage in our education, kind of learning about these diseases for the first time, it's helpful to look at them separately. So emphysema is sometimes called type A COPD, but it is by itself a standalone disease. Someone could have emphysema, and patients do have emphysema. Excuse me, the internet tried to kick me off. They have emphysema without chronic bronchitis, but it's called type A COPD. So, and I included some facts in here. Smoking is the major cause, but again, only 10 to 15% of smokers develop emphysema. So there is some genetic background that when you have the genetic makeup, you just don't tolerate smoking as well, and you're more likely to go down this path. There is a genetic cause of emphysema, an alpha-1 antitrypsin deficiency. That is a protective protein in our lung, and I'll add that into the story so you can see how patients who have the genetic cause, where it comes in. So to understand the pathogenesis of emphysema, it's important to first kind of review how our body normally responds to an irritant. Our body is so good at keeping our lungs sterile and fighting things off if something happens to get in. If you get an irritant that makes it down into your lungs, you will have an activation of your inflammatory cells, right? Your body is going to attack that invader. Whatever it is that made its way in that shouldn't be there, we will attack. So as you guys know at this point, once the white blood cells show up, they're going to do their job, but that will result in the area where they're fighting, the production of cytokines, proteases. Really specific to our story is going to be elastase, is a type of enzyme that degrades elastin. Elastin is really what gives our lungs their stretch and their rebound. If you've ever had someone describe the lung as like a balloon, right? You can blow the balloon up, and if you just let it go, all the air will come rushing out, right? Because the stretch on the walls of the balloon has a lot of elastic recoil. That's elastin in our lungs, that protein that can bounce back, spring back, and actually push our air out without any muscular effort. And of course, reactive oxygen species are going to be on the scene if white blood cells show up. So the negative of having an inflammatory cell activation is they're going to break down the tissue. They're going to break down the extracellular matrix. They're going to cause damage to the alveolar wall. As it says under the point B in your notes, the negative effects that might happen in your lung, we have protections from those. So if you get an irritant in your lungs, you get an inflammatory cell activation, your body has alpha-1 antitrypsin protein that is an anti-protease. So it basically blocks, a line with a line in the bottom of it shows inhibition. It blocks the action of the elastase. This is protective to your lung. It's almost like our body was like, we know they're going to need to cause some damage, so let's make a protein that prevents them from damaging us too much. That's alpha-1 antitrypsin. We also have repair mechanisms that as soon as there's damage, we're going to start trying to repair it. So if you get a little irritation in your lungs and you have a small inflammatory cell activation, you'll basically repair at the same rate of damage, and there won't be any long-term effects. This is what's in place so that our lungs can stay happy and healthy over our lifetime, even if we occasionally get some irritants into our lungs. The problem comes with this disease when let's put it the way it is in your notes. The problem happens when there's an imbalance between the amount of protease activity and the ability of anti-protease to prevent the destruction. So this is why smoking is on here. Smoking and other toxins can lead to this imbalance by having so much of an irritant in the lung that it overwhelms the system and it causes too much damage, and the protective mechanisms can't keep up. There's just too frequently are irritants being exposed to the lungs that you can't keep up. The other reason you might have an imbalance between the breakdown and the build back up is patients who have alpha-1 antitrypsin deficiency. If they don't have this protein that inhibits elastase, then even minor irritants in the lung kind of go unchecked. And minor colds, little viruses actually cause damage over time that accumulates and ultimately presents as emphysema. So the pathophys of emphysema is an inflammatory cell-driven activation that degrades the proteins of the lung, specifically elastin. And this is why, if you had to give this disease kind of a generic term, this causes a floppy lung. Because if you think of a balloon that you've blown up really big, like over and over and over again, its walls kind of no longer have that nice stretchy springy rebound. And if you blow it up, they'd be really easy to blow up, right? There's almost no resistance. The air goes in, no problem. But then when you release it, the balloon's not going to fly all over the room. It's just going to kind of deflate in your hand because there's very little elastic recoil left in that balloon. The out of balance breakdown of proteins leading to destruction of elastin causes the lung to become floppy. It reduces the ability to get air out because the elastic recoil of our lung is what primarily drives the pressure gradient to get air out of the lung. So emphysema is a floppy lung due to the breakdown of elastin. There are two types of emphysema, and they're described by where the lung is affected. Centroacinar is when the respiratory bronchioles are affected. Panacinar is when the terminal alveoli are affected, as well as some of the respiratory bronchiole. This doesn't really change their clinical description at all, but those names you might hear, and for some reason they often are in the board review book, so that's why I make sure to include it in your notes, even though clinically it doesn't matter to us a whole lot because the patient still looks like a patient with emphysema, irregardless of where that damage occurs. So on the left, you can see an image of a normal, healthy lung. On the right, a lung with emphysema. You can see much big, large gas spaces. When the alveoli get destroyed and we lose elastin, we get coalescence of our alveoli. And we're going to talk about this again. But, our alveoli are really like little grapes. I should draw these as full circles. They're like little grapes on the end of a vine, each one with its own capillary network to do gas exchange. When you have emphysema and the walls get damaged, these alveoli coalesce, and instead of having tons of little grapes, you get these giant alveoli on the end, and you can see that as very large air sac spaces in this lung. We will relate this back to the clinical presentation of this disease as we go through our lung review, but it's important to know that we've lost the elastic recoil of the lung, and we no longer have lots of little tiny alveoli, but we've got kind of big coalesced alveoli. That brings us to chronic bronchitis, the other type of obstructive lung disease. This is under that bigger category of COPD. When someone presents with more chronic bronchitis than emphysema, they are labeled as type B COPD. Chronic bronchitis is an interesting one in its definition because there is not a clinical test for this. There's no circulating biomarker that you can do. So as you see, the definition can be a little unsatisfying, but this is how it's diagnosed. Chronic bronchitis is when a patient presents with cough with sputum for at least 3 consecutive months in 2 consecutive years. So for 3 months straight, they're having a productive cough, and that occurs in 2 years in a row, you get diagnosed with chronic bronchitis. So unlike the previous 2 diseases, both emphysema and pulmonary fibrosis were occurring way down here, deep, deep, deep in the lung. The term bronchitis tells you there's inflammation of the bronchioles. So we are actually going to be in the more upper airways, in the bronchioles that lead to the ultimate place of gas exchange. So we're going to be a little higher up the tree now in our thinking, and that's going to really impact when we start going through how these diseases present clinically. So I mentioned our lung is very good at staying sterile. And in the previous example we talked about, if something actually manages to get past all the barriers, then we attack it with inflammatory cytokines. The story of chronic bronchitis, since it's happening in the bronchioles, actually has to do with that mechanism of keeping the lower lung sterile. So this diagram, on the left you can see the actual cilia. On the diagram on the right, here they are, the little hair-like projections on the inside surface of our bronchial wall epithelium. Sitting on top of the cilia is a mucus layer. And this mucus layer is really important because when you breathe something in, let's say like dust particles, it gets stuck to it. It gets stuck to the mucus, and then the cilia, oh my gosh, my daughter's baby doll is named Celia. And so I hear the word Celia about 1,000 times at home. And now I cannot say Celia without saying her name. She will be very happy to know that Celia made it a mention into this lecture. But I apologize that Celia keeps popping out. It's my daughter's most beloved baby. Okay, so the cilia beat in a general direction upward towards the mouth and move the dust particles back up. It's called the elevator, right? The mucociliary elevator. And they slowly raise them up the levels, and we get the things out of our lungs. So important in here, right, we have our goblet cells, which create the mucin, the main ingredients of the mucus. And then we have our mucus secreting glands, our mucus glands. So this is how our body defends itself. That lays the backdrop for the pathogenesis of chronic bronchitis. So the cause is, again, repeated exposure to an irritant or toxin. And the most common cause is exposure to cigarette smoke. So if you have extra particles, our body will always try to change itself to do its job better. So in response to repeatedly having elements that you need to collect and remove, the body's like, all right, we need to do a much better job. Let's increase the size of our mucus secreting glands. And you get hypertrophy of the submucosal mucus glands in the trachea and bronchi. Again, way up at the top, right? In these upper airways, the mucus glands actually get bigger. So if the job of the mucus gland was to secrete mucus, if it's getting bigger, it's doing its job even better. We're going to see mucus hypersecretion in the upper airways. Okay, so the first thing that happens is I shouldn't say first. The first thing in your notes that happens is the hypertrophy of the submucosal mucus glands. If we need to make more mucus, we're going to need more of the ingredients that make that mucus, which are our goblet cells. So we also see increased numbers of mucin-secreting goblet cells in the epithelium of our smaller bronchi and bronchioles. As we've gotten better at making mucus, that is not a good thing. This is going to get in the way. Our airways have a diameter to them, and we want the diameter to be big enough to let air get in and out. If you start having mucus hypersecretion, you are going to decrease the diameter. You're going to make these airways smaller because there's more mucus. And when you get into those smaller airways, you can really get in trouble because you can actually completely plug the bronchioles. Mucus plugs is when the entire diameter of the small airways get filled with mucus and then no airway gets through. We see that much in the distal bronchioles, the really small airways of our lungs. So now we have pulmonary airways that are making way more mucus than should normally be made. And exposure to repeated irritants is going to cause an inflammatory response. So we see infiltration of macrophages, neutrophils, lymphocytes in the upper airways. Again, we're in the airways, we're in the passageways that lead to the alveoli. Where emphysema, we are down in the alveoli. So in our airways, what happens when we have acute inflammation? We get edema. So now you can get acute edema in the airways. This is going to cause problems because if you already had reduced diameter from the mucus and now you add edema on top of it, you can dramatically reduce the diameter of the airways even more and make it very difficult to breathe and to get air out. Over the long haul, if you have repeated bouts of inflammation, you're going to end up getting scarring in the upper airways, and you can have chronic fibrosis of the upper airways. So that's very different than pulmonary fibrosis, which was down in the alveoli that scarred the alveolar capillary membrane. The airways become fibrotic and they're going to be less responsive, being unable to dilate when you need it and make it more and more difficult to manage the flow of air out of the lungs. So in this picture, you're looking at tissue from a normal person on the left and chronic bronchitis on the right. You'll notice all the little circles in here. All the circles are the glands. So you see tons of glands, right? They just had so many more than what you see on the other side where it's normal. And then you can see this beautiful little cilia on the top of the normal. That's on the top of the columnar epithelium, has all those little hairs to trap and beat, and they're just completely lost in chronic bronchitis. We actually see metaplasia here, where the ciliated columnar epithelium is replaced with stratified squamous epithelium, which seems counterintuitive because that's not going to help beat these irritants out. So the changes that happen in response to the repeated irritants ultimately make you worse at getting the irritants out. So where pulmonary fibrosis was a stiff lung and emphysema was a floppy lung, chronic bronchitis is inflamed bronchioles. Doesn't have as ring of a thing to remember, but you know, if we keep thinking about the balloon analogy, and we were talking about, an emphysema, you have blown up the balloon way too many times, it's completely lost its stretch. Chronic bronchitis is like if you take Vaseline and line the nozzle of the balloon. And now there's thick mucus obstructing the diameter and making it difficult to move air through. So chronic bronchitis is inflamed bronchioles and increased mucus. If you turn your notes, I think our page numbers are right. It's the very last page of the pulmonary disease notes section, page 113. I created this review chart for pulmonary disease. And it can be helpful to add this in as you go, or when you're going to study at some point, fill this chart in. I'm going to do it with you as we go through each of the elements of pulmonary function and how these three diseases are affected. But I start with just the basic difference, or the big diff as I put in my chart. I realize yours says basic difference, which is much more noteworthy than big diff. Big diff works for me. Here's the big diff between them, okay? Emphysema. If you can remember one thing and keep going back to it, it'll help make everything make sense. The emphysema is the destruction of elastin Elastin is that elastic recoil protein. Emphysema is a floppy lung disease. The lung becomes floppy, and you might even want to write because of reduced elastin. This will be the driving factor to the pulmonary clinical manifestations of emphysema. Chronic bronchitis, the main basic difference, the driving pathophys of chronic bronchitis is inflammation in your bronchioles. And if you want to write kind of a little cue for that, it's increased mucus along with that inflammation. That is going to decrease the diameter of the airways and impact lung function. And lastly, restrictive pulmonary fibrosis is a disease of abnormal wound healing. So because the body reacts inappropriately with way too many fibroblasts and myofibroblasts, it scars down the alveoli, wrapping your balloon in thick scar tissue. So it's really hard to get any air in. You can't stretch the walls at all. So this is our stiff lung. Maybe we could write progressive scarring. Ooh, scarring. So these are the three main diseases that we're going to use. And when we come back in the next video, we are going to start at the beginning with a basic anatomy review and then go through pulmonary function, always relating it back. Here's what's normally supposed to happen. So here's what happens in each one of these diseases based on their underlying pathophysiology. So I'm at about 42 minutes. I'm going to end the video here so we can pick up that discussion all together in one video. Have a wonderful day.